I think one of the biggest mistakes that families may make is not being accepting of hospice early enough in the decline of their loved one. I think the reality is, the science behind this is that we know that patients that are on hospice typically live longer than those patients that don't receive hospice for similar diagnoses. There are many reasons for why patients on hospice typically live longer. I think that some of the benefits, some of the robust types of services that are offered under hospice care, including symptom management, pain management, spiritual support, psychosocial support, the emotional side of what people and patients are going through. Those are all supportive things that I think many times our focus is pain management and the physical piece of the patient's decline. But there's so many other pieces of care that hospices provide that I think patients and their families will benefit from earlier referrals. I think it's the challenge for doctors as well as patients is, when is it time? When's the appropriate time to refer? And I think that, it can sometimes be challenging, and there's nothing wrong with having a referral made to hospice to have an initial evaluation done by a hospice nurse or a hospice provider to say, are we at that point with dad or mom? Is this something that we would benefit? Sometimes the educational piece of just the initial evaluation is helpful for families to reflect and say, I think this is the right time that we should start this. It doesn't have to be about the scary H word that means to folks, if I push the H word away, maybe I can just ignore the fact that I'm declining. Patients know they're declining. They know that their train is slowing down. And so I think that we as family members really have a responsibility to honor our loved ones' wishes. The physician paradox is that our training teaches us to help and to cure and to treat patients, and we feel some sense many times of not being smart enough to be able to have another solution to a patient's overall decline, when in fact we know in our hearts, here's a patient that probably does have a short prognosis and would benefit from receiving hospice care. So I think that late referrals to hospice continue to be a challenge. I think that in some environments things have gotten better, but it is, I think, for me, probably more likely to get more traction from the lay public. I think that physicians have limited time in their office. The busy hospitalists and physicians in the hospital sometimes are challenged to have those conversations, which really take not 5, not 10, not 15 minutes, but more so series of conversations about what a person's prognosis really is and what is likely to benefit them at this point in their life. So I think as consumers, my recommendation always is, you may be the one to start the conversation with the doctor. It seems like mom is declining. This is her 4th hospitalization in the last 3 months. And I'm wondering, every time we are admitted to the hospital, or she's admitted to the hospital, she's in for a day or two, she seems better, she goes back home within a couple of weeks, her symptoms are returning, and we're challenged again with, do we bring her back to the hospital? Is there another way? Is there something else we should be thinking or considering? I think that's an entry point for me, that I think consumers can allow the physician to feel more comfortable, sort of the carrot has been given to them. All they have to do is seize the carrot and really be honest, because I think they know in their hearts what's likely to happen for this patient. One of the real gems in my day is seeing patients in their home when they've been referred to hospice. The opportunities there are to really discuss with them in the home questions that clearly you know they have. So what does this mean? What is likely to happen? Addressing what are their fears? What do they know about what is likely to happen to them? What are they fearful of? Also addressing what are their goals. Many times they have very, very distinct goals, not only short-term but long-term goals. I saw a gentleman a little while back. His goal when I saw him and admitted him to hospice seemed minimal, but really very big for him. The two goals he had were that he wanted to be alive to witness his next birthday that was coming up in a couple of weeks. And he also wanted to be present physically at the baptism of his newest granddaughter. So for him, his fear was he was not going to make those two goals. And while I didn't have a crystal ball, I felt fairly sure that given his diagnosis, given his illness burden, given his symptoms, those two goals were achievable for him. I will say that one of his biggest impediments that he was fearful of was he was having a lot of pain from his disease, from his cancer. And he was leery of being able to leave his home to go to the church to witness the baptism. To which we talked about there are some options that we can talk about in terms of trying to reduce your pain. His eyes got big. He said, "Really?" And so I think that that was a fear coming in, that he was signing up for the scary H word. He felt as though these two goals that were very near and dear to his heart, he may not be able to meet. And at the end of our conversation, he was a guy that I think took a deep breath and felt some reassurance that while he was not going to outlive or outrun his diagnosis, he was going to be able to meet some milestones, meet some goals that he really had and he wanted to meet.